Mary Returns by Dr. Rizwana from Medicine 5.
Good morning, everyone. I'm presenting on the topic of Mary Returns on behalf of Medicine 5. So this is a case series of 3 patients who was admitted last week, all of them in the near date of admission of 25 to 27, with just an observation of all these 3 patients. All of them are middle-aged, and 2 of them are students, and 1 was a laborer working in Chennai. And demographically, they all belong to Vellore. And the symptoms they presented were high-grade intermittent continuous fever for 2 weeks and loose stools in patient A. And patient B also had a similar complaint, high-grade intermittent fever with lower abdominal pain and loose stools for 2 days. And patient C also had fever for around 3 weeks along with GI symptoms. Past history was not significant in all the 3. Travel history-wise, only patient A had a history of travel to Chennai, and history of food intake outside was all present in all the 3 patients. Treatment history-wise, only patient C had a course of antibiotics, cefixime and ciproflox for 5 days outside. Examination-wise, patient A was dehydrated and patient C was pale. Patient B was on general examination was normal. Temperature were all high-grade temperature at the time of presentation, up to 103 and 104 degree Fahrenheit, with a pulse rate suggestive of a relative bradycardia. And since he was dehydrated, the patient A had a BP of 90 by 60. The other patients had a normal blood pressure, and all of them were sensorium-wise normal. Systemic examination, all the systems were unremarkable, all they were normal. And investigation-wise, patient A had a total count of 5,400, patient B had a 4,600, and patient C had 11,000. And all of them had a normal platelet count. And this patient A alone had a creat of 1.27, but the repeat creat was normal. Probably it was because of a dehydration. And all transaminases were also normal. CRP was elevated in all the 3. And vital was negative in patient A and B, and patient C, H antigen showed a 1:320 dilation positive. So, what could the blood culture have possibly grown? Any guesses? There's no. Yeah, it's obvious. It's Salmonella typhi. All the 3 of them grew within 10 hours. It's actually time of detection is wrong in this first. It was immediately responded, and all of them were susceptible to azithromycin, and only patient A had a resistance to ciprofloxacin. So, yeah, the diagnosis is enteric fever. Systemic disease wise, enteric fever is a systemic disease characterized by fever and GI symptoms. It is called as typhoid because of its similarity to typhus. It's an exclusively human disease with food or waterborne transmission and incubation period of 5 to 21 days. We are all well aware of the symptoms and the findings seen in an enteric fever. Diagnosis wise, blood culture has a 60% sensitivity. And thing is to be noted is blood culture should be sent with a 20 ml at least for increased yield. And bone marrow culture sensitivity is very specific and sensitive also, 80% sensitivity. Even after a course of antibiotics, bone marrow culture will can show a salmonella typhi, whereas a blood culture may not show. Vidal test, stool culture can be positive in 3rd week. Vidals is it depends upon the location, the sensitivity and specificity of the viral test varies, and rapid test available typhi, dot, and tubex. So my the take home point of my presentation is there is a surge of enteric fever in the last week, and it's very unusual during this period of season. Usually it is common during the pre-rainy seasons or during the rainy seasons. In February, and there is and not only in our unit, I guess the other units may have also seen a surge of enteric fever. So this is an antibiogram of our CMC itself, which shows sensitivity is only 1% in ciprofloxacin and aldic acid is 16%, whereas all of them are around 87 and 90% are susceptible to azithromycin. So what when a patient comes with enteric fever, we have to look out for certain complications. We did have these 3 patients whom I presented now did not develop any complications in the last week, but we have seen complications in the past 6 months. Around 2 months back, we had a presentation of cystitis and nephrotic syndrome also, which was present in a previous clinical meeting 4 weeks back. And CNS wise, they can develop a complication of encephalopathy. It is characteristically called as muttering delirium or a coma vigil, and where the patient will have imaginations of picking objects and picking up imaginary things. And other than that, they can develop an cerebral edema, Guillain-Barré syndrome, meningitis, abscesses. And cardiovascular wise, 1 to 5% can develop endocarditis, then toxic myocarditis, also pericarditis, and congestive heart failure. Pulmonary wise, they can develop pneumonia, empyema, and bronchopleural fistula. They can also seed into bone and joints, causing osteomyelitis, and other organs as well, causing hepatic abscesses, splenic abscesses, and chronic carriage in patients with cholecystitis can lead to a gallbladder carcinoma also. Genitourinary wise, it can cause a cystitis due to infection, renal abscesses, nephrotic syndrome, or rapid glomerulonephritis, which is present in 4 weeks back. Soft tissue also it can seed into. It can cause psoas abscess, gluteal abscesses. Hematologically, only 5 cases have reported of hemophagocytosis syndrome. So how can we prevent the enteric fever? Because we are very well aware of the treatment. What is the prevention is basically we can prevent it with safe, adequate sanitation and hygiene. Vaccination wise, the 2 vaccines we have been using it for a long time. One is the typhoral vaccine, that is a live attenuated oral vaccine. Other is the VI polysaccharide vaccine. There is a new vaccine that was approved in 2018. Can anyone? That's my question of interaction today. Mm. The question is, what is a vaccine? Typhoral is a live attenuated vaccine. Yes, that is already been there from 2008. VITT, yeah, that's correct only. VITT. That is actually a conjugate vaccine, which is conjugated with a tetanus typhoid. So this is the new vaccine approved from 2018. It was actually FDA approved from 2013 itself, produced by our indigenous Bharat Biotech, and it's been recommended by IAP also at 6 months of age. So comparing all the three, that is a typhoid conjugate vaccine and unconjugated VI polysaccharide vaccine and live attenuated vaccines. So the advantage of conjugate is it's an IM and it's a single dose, and it can give from 6 months onwards. So other 2 vaccines we are well aware of. So the take-home point is that there is a sudden surge of enteric fever cases in our hospital, and what are the complications we should look out for and the prevention strategies. Thank you.
Thank you, Rizwana. Does anyone have any questions?
I think the thing to point out is all of these people are they have a very high fever and they have prolonged fever. But when you look at their WBC count, that's the classic thing that you will see with typhoid.
Yes.
Unlike most other bacterial, you're expecting this very high count. And you will see there are various theories for that. But you look at your thing also, and it's usually a relative neutropenia also.
Yes,
for someone who is 103, look at your fevers. So that itself, it's usually a well-looking patient with very high-grade fever and no leukocytosis. You're almost thinking entry, even if you don't have the GSM. GI is there, it's usually 2 + 2 = 4. But otherwise, the counts is what leads you to say, hey, my culture may form of a typhoid. This my differential is going to be a typhoid. Versus, of course, the complications that you mentioned. So the psychosis part, what you mentioned, is called bed picking. They tend to pick the. I mean, we've seen it sometimes. You don't have to see it all the time. But most of the time, by the 3rd week, you're worried that they don't have complications. But the main thing is those counts. When you look at the counts, for someone with such high spiking fever for so long, that itself tells you the direction is there. But the theories for it are varied. For why there is a neutropenia or leukopenia.
At this point, we are also having H3N2 coming with gastroenteritis. So your counts are again, fever is going to be high, counts not very high, but there is tachycardia attack. So I think this point in time, we are having a lot of outbreaks. Chicken pox.
So as you pointed out, also bone marrow culture is a thing which you don't even need an appointment for. You can just do the
Just
culture.
culture. Just culture.
Thank you to all the presenters. I would once again like to remind everyone to immediately after you put your history and examination, summarize the clinical syndrome and commit to a set of differential diagnosis or differentials before you move on to investigations. So today I'll give the prize for the overall presentation to Rizwana.